This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here this morning with Dr. David Gerber, one of our CSAP 17 authors. David, can you share with our audience a little bit about yourself, where you're located, what's your primary focus of your clinical practice, and maybe a little bit of how you spend your usual day or week, if there is one of those?
Sure. Well, thank you, John, and thanks for the invitation to join you on the Audio Companion. So I am a comprehensive transplant surgeon, primarily liver, kidney, and pancreas transplant. I'm the director of the Transplant Center at the University of North Carolina and have been in practice 2+ decades now. And you're right, I don't think there is ever a typical week, but there's a fairly typical week between living donor kidney transplants and deceased donor transplants. I also have a sizable hepatobiliary surgery practice which focuses on primary liver cancer and primary liver masses. On top of that, I've been blessed or not as being the vice chair of clinical affairs for our Department of Surgery. So I have definitely picked up some more administrative roles as the years have gone on.
And I'm sure those are just totally enjoyable.
They are very pleasant and easy to work with people, all day long.
Okay. Well, I thank you for that, and I thank you for giving up some of your time to spend that with me this morning to talk about hepatobiliary disease as well as transplantation. Most of the topics we're going to touch on are found either in the abdomen or the related specialties category of CSAP 17. And I've picked some of the topics actually from CSAP 17 questions, but there are others that we discussed in many of the committees that didn't make the final cut, but I remember them because there was quite a bit of discussion. So I'm going to pick your brain about what you thought about that discussion and about that topic. So let's get started. Let's start with liver cysts. And let's first exclude parasitic and infectious cysts and come back to them a little bit later. But how about starting with congenital cysts? What does a general surgeon need to know about the possibility of seeing a patient that has a congenital cyst?
Sure. So I think the first part is to realize that probably 5% to maybe 10% of the population is going to have a congenital cyst, or what we refer to as a simple cyst within the liver. And for a general surgeon, I think as patients are getting imaged for many different things when they come to their providers, these are being picked up incidentally, and they typically are referred to the general surgeon, depending on the community or hepatobiliary surgeon, for recommendations on management. Simple cysts are just that. They don't have an epithelial lining, and really the management or indications for management of simple cysts is based on symptomatology. So I tell patients if they're found incidentally and that patient has no complaints that I can specifically ascribe to the cyst, I tell them, go back home, enjoy yourself, and be happy you don't have to see me again. If for those patients where it gets a little bit more binary in the other way is the person that comes in with very discrete abdominal pain and on imaging, they have a large cyst, maybe 12, 18, 20 centimeters in size, and that's very clear that the patient's symptoms are associated with this large cystic mass. We have a couple of options on how to manage those. It's important to try to do this one time and be definitive, and now with minimally invasive surgery, many of us will do a fenestration of the cyst, meaning unroofing the cyst and excoriating the inner wall so it doesn't sort of seal back on itself. And that gives patients almost instantaneous relief, depending on how symptomatic they were from the cyst. The gray area is in the middle patient. The patient that has some vague abdominal complaints has a cyst that's, kind of like Goldilocks. It's not too small and not too large. And you struggle to say, is that cyst contributing to the patient's symptoms? For those patients, what I recommend, and I think different providers approach this different ways, we would go ahead and recommend percutaneously aspirating the cyst to see if the patient's symptoms improve. Knowing that aspirating a simple cyst, the cyst is just going to fill back up. But if the symptoms don't change with the aspiration, then we haven't put them through a general anesthetic and abdominal surgery. If the symptoms do improve with the aspiration, then when their symptoms return, I have them come back in and we kind of go back down plan B. So that's the simple cyst, and that is what the majority of general surgeons are going to see, but the important thing for them, and this is where I think the improvement in radiology imaging has played a role, is the discrimination between a simple cyst and what are called biliary cyst adenomas or more complex cysts, staying away from infectious cysts. The biliary cyst adenomas are different. These are cysts that are complex. They have septations. They oftentimes will have abnormalities that you'll note, nodularity along the wall of the cyst or along the septations. There are thin septations that are not worrisome. There are thicker septations that sort of give more character to the cyst. These are the cysts that we have to have a more involved conversation with the patient because there is a risk for malignant transformation. For the general surgeon, I think at this point, if they're dealing with a more complex cyst, I would recommend that they have this patient seen by somebody that does hepatobiliary surgery on a routine basis rather than tackling it themselves, because the recommendation really is either a nucleation of the cyst or a formal segmental resection of the liver involving the cyst. But the complexity of the conversation really deals with age of the patient, other comorbidities, et cetera, and that is a more involved conversation.
Let me just ask you, David, so you said enucleation versus surrounding hepatic tissue being resected. How do you decide, and is there a margin that is usually used when you're resecting a biliary cystadenoma?
So I'll answer the questions in an inverse order, but it's great. So you don't need a margin. You just have to make sure you get the entire cyst out. So this is where expertise in hepatobiliary surgery comes into play. If you can safely and successfully just remove the cyst, enucleating the cyst from the liver, really it's going to be based on where the cyst is located in the liver, then you should go ahead and do that. Sometimes because of how integrated the cyst is within the liver, you can't just enucleate that. It's going to be easier to either resect one or two segments of the liver where the cyst sits, then you should go about that. And this is more of planning, how do we do the safest operation for the patient with the least morbidity. But going back to the first part of the question, the margin can be, a 1 millimeter margin really is, or a 0 millimeter margin. You just have to be removing the cyst. You don't want to leave any part behind.
I have another question that has always bothered me because I have fenestrated a number of liver cysts, congenital liver cysts that were symptomatic. I've always wondered why adhesions, especially the way sometimes the liver sticks to the anterior abdominal wall after you manipulate it a bit, doesn't cause a recurrence of the cyst. Is that a problem or not?
John, you always ask great questions. And, so you're right. With manipulation of the liver, certainly we're going to get intraperitoneal adhesions. And the issue of recurrence occurs based on how definitive the fenestration procedure was. And where I've seen what I would call failed procedures is where a surgeon goes in and he or she goes to fenestrate the wall of the cyst. They may not be comfortable taking out too much, so they take out a small, maybe a large postage stamp size of the cyst. The cyst decompresses, but what happens is the liver then adheres to the anterior parietal peritoneum or lateral peritoneal wall, and that basically creates a closed cyst again, and the symptoms return. And that makes for a very unhappy patient and a somewhat sheepish feeling of the surgeon. Obviously, I deal with a lot of trainees in these procedures, and when I talk them through, I emphasize to them that you really want to fenestrate as much of that cyst as you can successfully do without causing a more complex operation, right? The balance between risks and benefits of what we take on.
I'm glad to hear you say that because that's the way I was taught, and it always made me feel good when I could fenestrate almost the entire cystic wall, at least the anterior wall, let's put it that way. So good to hear. Now, how about polycystic liver disease? That patient that I get to see every once in a while, which just looks like their liver is fenestrated all over the place.
Right. It looks like a sack of soap bubbles, or that's a fascinating disease. And obviously, as with many of the polycystic diseases, there is a spectrum from those patients, and typically we're talking about, well, there's the autosomal dominant polycystic kidney, polycystic liver disease patient. There's a recessive gene also. But when we look at polycystic liver disease, there's the patient that has quote unquote polycystic liver disease, but they only have, say, half a dozen or more cysts. They're not very large. They still, under radiologic definition, are polycystic, but they're not, cumbersome to the patient. The other end is the patient you were referring to that walks in with significant polycystic liver disease and associated hepatomegaly. And this also comes in a spectrum. There have been some innovations in the last decade or so. Sometimes the cysts are asymmetric, and I've had cases like this where maybe the segments 2, 3, and 4 are more involved, and segments 5 through 8, which is the right side of the liver, are less involved, or that we'll say liver spared. If that patient is symptomatic from the hepatomegaly component of the polycystic involvement, you can actually go in and do a hepatectomy of the involved segment, because you're not really removing any liver parenchyma, but this gives the patient relief. And I will say, I've only done this maybe a handful or so times that I've had the opportunity. It's a fascinating operation because it's almost like you're going through, like foam balls, so to speak. It's such a different architecture compared to the ecotexture of the non-involved liver. Now, take it one step further. There's the patient who has significant polycystic liver disease with hepatomegaly, and I think of a patient who I recently transplanted whose liver weighed 45 pounds. Now, when your liver disease is that advanced where it's debilitating, that really is where transplant plays a role, because there's no way to just decrease the volume or the impact of that liver when the hepatomegaly is so advanced. And obviously that is a very extreme case. But I've certainly seen, again, a number of patients with advanced polycystic liver disease where their livers are 4 and 5 times normal size for their body weight.
And with polycystic liver disease, there is no risk of malignant degeneration. Is that fair to say?
You love asking the challenging questions. So to the extent that we know, there is no risk of malignant degeneration in that polycystic liver disease patient. But I will add that I have seen one case where a patient did develop a primary hepatocellular carcinoma in the setting of polycystic liver disease. That is extremely rare. Rare enough that I was able to successfully write a case report.
Ah, it's always good for your CV. Okay, let's move to liver abscesses, and let's start with pyogenic. Now, it used to be that the etiology of pyogenic abscesses was supposed to be from the right colon and the drainage into the portal circulation. And more recently, I've seen a lot of papers that really the biliary tract is the culprit. How does the hepatobiliary surgeon look at this?
You're right. Historically, the dogma or the literature in our educational pieces was always associated with diverticulitis and the right colon. As we're seeing more biliary disease across the board, and as our interventional endoscopists have really expanded in what they can offer, we do see more pyogenic abscesses of the liver that are associated with biliary disease. I don't have a specific number that I can quote in this situation, but we have a very close relationship with our interventional endoscopy team, and I think because of what they can do, we are seeing an evolution of disease process of what we're being asked to manage. These are patients that develop biliary strictures post-cholecystectomy, or they have underlying say, sclerosing cholangitis, either primary sclerosing cholangitis, which is more of an autoimmune disease, or secondary sclerosing cholangitis, which can be secondary to multiple stones, pancreatitis, and other etiologies. But you're right, we are definitely seeing pyogenic abscesses in that population. And then still the patients with, a history of IV drug use or any illicit IV use are at risk for pyogenic abscesses.
And aspiration and drainage is still routinely used as treatment for most of these. Fair?
It really is. It's aspiration and drainage and antibiotics that, literature evolved over the last probably about a little more than 10 years ago, where I know certainly when you were training and I was training and surgery was probably more frontline in management, we have definitely been moved back to sort of the third line of therapy. What's interesting, though, is that we still play a role. There are patients, especially with some of the more atypical infections, where hepatic surgery is necessary because the antibiotics, patients have been on suppressive antibiotic, and they can only go so far, and the patients have been stuck numerous times with catheters. And again, this is an important collaborative relationship with your infectious disease colleagues, where they'll come to you and say, hey, here's a patient, we've exhausted what we can do percutaneously and with systemic antibiotics, and what do you have to offer? And I probably do 2 or 3 of those a year, so it's not a large number, and they're all usually very either fungal infections or mycobacterial infections, typically in more of the immunocompromised population. Certainly, they're a more complex patient population across the board.
And I bet you many of them are high in the liver, and so access is sometimes a problem for the catheters. Right,
exactly. Location.
Yeah. So you're still using a Coker approach to approach that sometimes?
It depends. I have definitely moved to do as much as I can minimally invasive, from a minimally invasive standpoint in managing these. They typically don't have underlying liver disease, which for me is very unique because most of the patients I deal with have cirrhosis or advanced fibrosis. So I feel very comfortable, and I'm very happy to work on somebody when their underlying liver is relatively normal. And from a minimally invasive approach, you certainly can get to all 8 segments of the liver, but certainly the right posterior superior region is the tougher area to get to. And if you're draining an abscess, there a Coker incision affords you better visualization and mobilization of the liver.
Well, lastly, let's talk about the type of cyst that is always fodder for test questions, and that is hydatid cyst caused by Echinococcus. You want to tell us your experience with this kind of cystic disease?
Sure. So I think for many of the folks who practice in North America, this is something they will see more on a test question than they will ever see in clinical practice. And even for those of us who do hepatobiliary surgery, the same would go true. Where we do get echinococcal infections, they are rare in the U.S., but they can occur. The patients that I've seen in my practice typically have either traveled overseas, lived overseas for an extended period of time and acquired the infection, and then end up in our domain. Obviously, one of my colleagues who is born and trained in India said, that's something you see every week in your practice, and not something we see every week here. Obviously, management of the hydatid cysts is very important. You don't want to get spillage. You want to have a very controlled resection so that they don't have an inflammatory response. And again, principally done by somebody that does hepatobiliary surgery, I would say for those patients is very important.
When you're talking about treating these patients, your friend from India probably talks about the pear technique, which is associated with hydatid disease. Have you had any experience with that?
I have not. I have read about it. He certainly has had more experience with it. And a lot really, it's because of the timing of the presentation. For the patients that we see, they, again, have typically been manipulated multiple times or treated. Usually the echinococcal infection has been previously identified. to elaborate on that, I can't think of a patient that I've had, and again, it's a limited number of folks with echinococcal hepatic abscesses who haven't already spent a year with an infectious disease consultant in management before they got to me. So it is a different than if you were in a nation where this is such an endemic problem that you're going to see these patients almost as frontline therapy.
Well, let's move on a bit, and let's spend some time talking about hepatocellular carcinoma. And from somebody who deals with this a lot, is this really increasing worldwide?
This is, depending on which reports you look at, it's one of the fastest growing cancers worldwide. It's always in the top 3 of total cancers and in the delta change. Part of that obviously relates to the vertical infection of the hepatitis viruses in Southeast Asia, where there's still a lot of Hep B and a fair amount of Hep C, although obviously we have new Hep C therapies, which is making an impact. But that across the globe and going into sub-Saharan Africa is still the hepatitis viruses are major contributors. Now, obviously, when we look globally and not specific with vertical transmission of the hepatitis virus, the HCCs, hepatocellular carcinoma, is rising in incidence. It's rising in incidence in both Europe and in North America, more in North America than Europe, but rising on both continents for several reasons. Initially, we spoke about Hep C. Before we had a cure for Hep C, Hep C was the number one contributor, that along with alcohol in the North America continent and Europe. But now with non-alcoholic fatty liver disease, or NAFLD, NASH is also, initially we thought NASH, doesn't really cause HCC, doesn't have the same underlying contributors, but we are clearly seeing patients developing HCC and their only risk factor is the underlying NASH or NAFLD condition. What's interesting is that in those cases, 2 things, and I think it's germane to the general surgery community in HCC. Just treating a patient and curing their Hep C does not completely abrogate their risk of developing hepatocellular carcinoma. So most of those patients have some underlying fibrosis or chronic inflammation, and the liver community is still working on trying to figure out how best to do surveillance on the population because, again, this is a cumulative incident, so length of time you have an infection, length of time you have inflammation, chronic inflammation are all contributors to developing HCC.
Well, that's interesting because I was going to ask you, when I watch TV and I hear all of the new medical treatments for Hep B and C, I get the feeling that this is all going to go away and we've solved the problem. So what you seem to be indicating is that may not be true related to the risk of HCC.
Correct. We, no question, we've made a significant impact from a societal perspective with respect to Hep C causing cirrhosis, leading to the indication for liver transplant or death from liver failure. But what people shouldn't get false hope is that curing Hep C takes the risk of HCC and drops it to 0. It does not do that.
So when you have a patient who has got the risk factors for HCC, how do you screen for HCC in that patient?
Do you want the textbook answer, or should I give you the clinical answer?
I'll take both. How's that? I'm sure our audience would appreciate that.
That's right. So the test answer, or the societal answer, has been ultrasound surveillance for HCC, and this has been hotly debated in both the European Liver Society as well as the American Association Liver Group, so ASLD and EASL. Both have struggled with that, and obviously how they came down upon ultrasound, it's the economics and the improvement in ultrasound. But if you look at practices in the West, most of them do screening with either high-fidelity CT or MRI. And the reason being is that ultrasound is very operator dependent, Now, this may change in the next 5 years, or it could even change by the time this audio comes out, but probably not that quickly. We are just now entering the age where in the U.S. we can use contrast-enhanced ultrasound as a diagnostic tool in the liver. That will definitely improve our ability to detect lesions in the liver and their correlation with these lesions being malignant or suspicious for being cancer is continuing to improve. So that may improve the operator components of this, but today that's not being offered all the way around, the U.S. or even Europe. So most of us are still relying on using MR or CT, depending on the preference of our institutions as a surveillance tool.
I was going to ask, is that just a preference of your radiologist, or is there really an advantage to either CT or MRI?
Yes, and yes, right? Like anything else, what I find in having spoken at RSNA, which is the big radiology meeting, and speaking to the radiologists, like anything else, you develop an expertise in a modality. So it's rare to have a center that is equally proficient in MR and CT, because you kind of train up on one versus the other, and you tend to order more and more tests down that way. So I've gone to and it's funny to listen to the radiologists, because they, of course, will say, no, it's one versus the other is better. But it's clearly both are very good as long as you're doing it a lot.
So you have an image that says the patient has a HCC. Do you need to confirm that with a biopsy?
No. So the recommendation in the liver community is that the new LIRADS diagnostic scoring system, which is similar to BioRads and similar to some of the others that have come out in the radiology literature, is diagnostic in itself. So it's a 1 to 5, and a LIRADS 5 is consistent with being an HCC, and the community discourages doing a biopsy for two reasons. One, doing the biopsy obviously puts the patient at risk for tumor seeding, because you're oftentimes doing a biopsy in a cirrhotic liver, so they typically have low and/or dysfunctional platelets. They're maybe slightly coagulopathic, so there's a risk of a bleed, and with that bleed you could have tumor seeding. The other part is HCCs, unlike metastatic tumors, they're heterogeneous, not homogeneous. So you can do a biopsy of a lesion for one. Targeting is one challenge, because the liver, from a 3D volumetric standpoint, it's not as easy to get to every part of the liver. But the question comes back, if you do the biopsy, and the biopsy comes back inconclusive or indeterminate, which can happen if you don't have a big enough core, and even if you have a big enough core, they'll say, well, it looks like cirrhotic liver. Does that mean it's not an HCC? That's why the imaging really does trump that, because that's giving you full assessment of the nodule itself, size, radiographic characteristics, change from previous imaging, and that has been now an accepted standpoint in management.
And so with the LVAD classification, obviously 5 is your HCC patient. What do you do with 1 through 4?
Right. So LIRADS, obviously 5 is a cancer. LIRADS 4 is a suspicious. It's a dysplastic nodule. Those patients typically you recommend repeat follow-up in 3 to 6 months, depending on how much preceding imaging you've had. A LIRADS 3 is a regenerative nodule. It's something, again, you would follow either maybe at a 6-month interval, depending on what else you're looking at in the liver, or if you have multiple prior images, you may be able to go out a year. LIRADS 1s and 2s are benign things, and so you wouldn't even follow those.
And so once you have that patient with a HCC, present management is?
Yeah, present management is they should be managed in a multidisciplinary care setting, because we really do have a lot of options in our armamentarium, which are sort of clustered in different ways, right? So you have the tumor in the liver. The question is, what's the liver? Is it fibrotic, cirrhotic, normal? You have the comorbidities of the patient. What can they tolerate? And based on that, we really do have a lot of options now. So for one, if we're looking at a single lesion that's under 3 centimeters, You could approach it many different ways. There's very good literature for local ablative technology versus surgical resection, both equally good for small lesions. There's a growing body of literature using what's called CyberKnife or stereotactic external beam radiation therapy, which is a more focused external beam radiation therapy. That literature has been growing. So if it's multiple lesions or a larger lesion, now you want to look at sort of multimodal therapy. That's where we bring in, again, resection is still an option depending on the underlying liver disease and the comorbidities of the patient. Transplant could be an option depending on the staging of the tumor at this point. If it's not a transplant candidate or maybe the tumor is too large for transplant, now we can look at ways to downstage or control the tumor or reduce its size, and that can be approached using either TACE, which is transarterial chemoembolization, or TARE, which is transarterial radioembolization therapy. Both have been well established to help, get local control regionally within the liver. They're not curative. And then maybe downstaging the patient to the point where transplant is going to be the option. Again, depending on the underlying liver disease, CyberKnife can still be an option. Or if we've exhausted those options, there now are some new agents, some of the tyrosine kinase inhibitors and the PD-1 inhibitors, PD-L1s, that are being used in liver cancer in clinical trial. So I think that, again, with every 2 to 3 years, we'll see more options coming into the armamentarium. But from a curative standpoint, the only true cures are either local ablation for the small tumors, resection, or transplantation.
There's a fascinating question in CSAP 17 about a patient with HCC that ruptures, causing a hemoperitoneum. Patient's hemodynamically okay, but I was amazed at the answer because I thought this can't be good. How do you handle that? And is it good or does it matter?
So it's definitely not good. We'll take that. That's the easy answer. But it's not. It may not be as bad as we thought. So spontaneous rupture of an HCC, again, I think gives us all tremendous angst. The body of literature around that is small but growing. Just because the tumor has ruptured doesn't mean the patient's going to have tumor seeding throughout the abdomen. And what most centers will do in a case like that, again, is treating the tumor. And again, this could be either resection, ablation, transarterial chemoembolization so it doesn't continue to bleed. All those are appropriate managements, but then close surveillance of the patient. And I know in our center's experience and others, it's maybe somewhat arbitrary of how long you're going to survey for, but I think most people would say surveillance for 12 months is going to tell you is something developing. Are they having intraperitoneal seeding? And what we have found is that that tumor rupture does not mean 100% tumor seeding. And there are patients in that scenario that have very safely and successfully gone on to transplant without any evidence of disease at the time of transplant and no disease recurrence after. Now, the N's are small, but I think even small N's are bigger than we thought they would be.
And so really you treat the tumor, but you don't necessarily need to do anything about treating the peritoneal space at the time of the rupture.
No role for HIPEC or anything like that at the time of rupture. Again, the series are small, but definitely growing. I think all of us say treat the tumor. We don't want this to continue to bleed. Get the primary cancer under control, eradicate it if possible, and then close surveillance would allow us to figure out what we have to do next. And there are cases where you do see tumor seeding or single nodule seeding. But like I say, it's not nearly as high as we would have thought.
Now, before we leave the liver, there is always a discussion at many of the committees about what do we use to evaluate liver dysfunction. And everybody says liver enzyme tests are not the best. And then we go into an argument between Child's Pugh and MELD scores. Can you give us a little update on what they are, and are they equal, and how should we use them?
Right, and that discussion point usually occurs right before lunch when everybody is getting hungry, and nobody ever feels that we resolve it at the end.
That is correct.
So I think it's important when we talk about Child's Pew and MELD, it's important to look at these from a historical perspective for what they were designed for. So Child's Pew scoring system, which was developed, if I recall, in the late 60s, was really a prognosticator for mortality associated with shunt surgery for patients with liver disease and portal hypertension. And basically looking at certain features of the liver, including albumin level, total bilirubin, presence of ascites, encephalopathy, INR, to say if we could categorize patients and there's a scoring system and you basically cluster them into a child's A, B, and C, you would say that, we know that if they were undergoing surgery, and this was specifically for shunt surgery when it was developed, that a child C had a 60% mortality at surgery, a child's B was around 40%, child's A was around 15 to 20%. Obviously, somewhat coarse, but it gave surgeons something that they could at least use as an educational tool to determine who should go forward for surgery. MELD, on the other hand, was developed through, again, it's an offshoot of the Mayo modeling system, stands for Model of End-Stage Liver Disease, is a prognosticator for what's the likelihood of a patient dying of their liver disease in the next 90 days. So some of the same parameters were used, but the difference is that in Child's Pew there were two subjective ones, which was degree of ascites and degree of encephalopathy. MELD scoring system uses total bilirubin, albumin, INR as contributors, also incorporates in the serum sodium level to give you a scoring system, again, starting at 0 all the way up. For all intents and purposes, we really focus on MELDs between 6 and 40 because that's where most of our patients live. And that is a predictor of death in the next 90 days. Doesn't really correlate to survival from surgery or even survival from transplant. But people have this argument, time and time again. I think both are, going back to your question was how do we best assess somebody's synthetic function when we're looking at them from a surgical standpoint, I think was how you were asking the question. And I think it's important that we look at this in a comprehensive way. So there are many centers that still will do ICG, excretion, if they have the ability to do that, to look at functional excretion of the liver. Most everybody would say if you're going to be doing liver surgery, if it's anything, where you're looking at multiple segments or a hepatectomy, you've got to do liver volume so that you can determine how much residual volume you'd be leaving. And then you have to factor in what's the underlying liver. Is it fibrotic, cirrhotic? Is the patient young or old? All of those things have to be incorporated. What most of us would say, and I apologize as I ramble on to your question with multiple points, when it comes to patients with advanced liver disease, where there is in general most consensus, we would say synthetic dysfunction as determined by the following two are poor prognosticators for surgery. And the first one being hyperbilirubinemia. And most of us would use a cutoff of around a total bilirubin around 2. But again, that's you can adjust a little bit north and south depending on your patient. And the presence of significant portal hypertension. And again, the sort of the starting point for most people has been a platelet count of 100,000 or greater being a criteria for being a surgical candidate. Now, again, I think as liver surgery has become more advanced, liver anesthesia is more advanced, our general care of the liver disease patient is more advanced, I think many of us would push that liver resection, for patients with platelet counts slightly below that, and bilirubin slightly higher, depending on what their albumin is, depending on what their, other comorbidities are.
I have to follow up one comment, and that is I remember doing the ICG clearance tests when I was in the lab as a surgical resident. And I have worked at a number of hospitals, and I have never seen that as being offered as a test that is clinically available. So at your hospital? Is that something the lab does for you, or do you have to have your team come in and do the ICG clearance?
Gosh, I wish you weren't going to ask me that question. So I have no idea if it's offered at my center. I don't use it, and I've never asked. I bring it up because clearly there are regional differences. So there certainly in Asia, it is used with high frequency. In several liver centers in Europe, it's also used, and there are select centers in the U.S. that use it. ICG, it's kind of funny, and you talk about that from your days in the lab, has made sort of this resurgence of sort of clinical application, and in hepatic surgery, there have been some recent publications, even since we did CSAP 17, using the ICG study as a way to identify tumors within the liver, but also to identify, as sort of a adjunct to somebody getting the ICG excretion test because of the way it's retained, and people are using it in biliary and other surgeries. So I am not using it, in my clinical practice. I don't know many people in the U.S. that are, but I wouldn't be surprised if it starts to grow just because it is being used in the operating room more than it was even 5 years ago.
Yeah, I'm seeing a number of papers that use it as an adjunct to identify the biliary anatomy for a difficult laparoscopic cholecystectomy. Am I right there?
Yeah. No, it certainly is. So it's very good. Depending, again, it's timing and dose related. So many folks are using it for the complex biliary anatomy. To do that, it has to be in the system for, I think it's 45 minutes to an hour to see it excreted in the biliary system. The imaging, partly because the technology has improved so much, is incredibly sharp. And there have been a number of publications there. People are using it in intestinal anastomoses, where this literature is also just growing, where people are using it to identify, they're doing a colon resection, or maybe somebody that's had mesenteric ischemia and they're doing bowel resections and they want to determine, do they think that the bowel is viable? They're using ICG because you'll see it excreted and you'll see hypoperfusion within the bowel because of the vasculature. And now also it's the first liver tumor papers just came out in the last 8 months.
Well, let's change the topic a bit, and let's talk a little bit about biliary disease, and in particular about choledochocysts. And we've got this, once again, we've got a classification system that I think everybody knows about, the Todani classification system. And do we need to worry about all of these, or can some of them be ignored, and which ones are important for us to know something about?
I think the ones that we need to, be focused on the most are certainly the type 1s. These are the ones that involve, they're complex, involving most of the common bile duct, and they can be up to the liver, usually not extending all the way into the liver. They can extend all the way down to the pancreas as well, so it can really be involving most of the common ductal system. And those are the ones that historically, again, when we see those, they're more often in younger patients, female, usually of Asian descent, and there is a malignant transformation risk in those. And it's important for us to identify those. And again, this is where our radiology colleagues do help, because those are the patients that should be referred for resection of the choledochal cyst.
When you say resection of the choledochal cyst, it's the entire extrahepatic biliary tree needs to be resected, or just where it's dilated?
Wherever the pathology is. So if the pathology extends down into the head of the pancreas, then it involves, a resection of the common bile duct and a pancreatic head of the pancreas resection. If the dilatation stops extrapancreatic, then you could resect at that point.
It's always amazed me, I'll ask you for your perspective, but it's always amazed me that type 5, or Caroli's disease, looks so impressive on whatever study you get to define it, and yet the risk of malignant degeneration is low. You got any thoughts about that?
No, it's, you bring up a good point, right? It's sometimes what looks scary may not be as scary as we think, and I don't have much, and again, it's a disease, it's an entity we don't see a ton of in volume, but, and that's why it's important if somebody does have ductal changes that are noted, and usually these are getting picked up now more on MRI, MRCP, it's important that the imaging get looked at by somebody that does liver imaging diagnostics, on a high frequency basis. I have seen cases where the initial read has not been accurate, and usually because it's coming from somebody who just doesn't see as much liver pathology from an imaging standpoint.
Well, let's move on to your other area of expertise, and that's transplantation services. So let's start with a little different approach. And obviously, transplant services have to deal with death, just like trauma services. And determining death is especially important when it comes to discussing possible transplantation. Now, recently, there's been a whole lot of discussion about using ultrasound to determine death, especially after a traumatic arrest. So now the ultrasound probe is put on, and if there's any kind of cardiac motion, there's some physicians that are saying we need to continue to try to resuscitate that patient. How does that fit with our, quote, old, unquote, definition of death?
Boy, this is where I say this is tough for you, the trauma surgeons that are in the front line. For us, it really hasn't come all the way across to our, I hate to say the accepted or the definition of brain death and cardiac cessation that comes to the organ procurement side of things or organ donation component of things. We have not yet changed the definitions or acceptable definitions of death, which would be the absence of neurologic function for the brain dead donor. And that can be diagnosed several different ways, including 2 separate serial clinical exams, assuming other, physical characteristics are met, or it can be done with imaging studies as well as a correlate rather than the physical exam. But we are not yet at the point where we've incorporated the ultrasound evaluation as part of the death designation.
So your donation after cardiac death would not be impacted by somebody putting an ultrasound probe on the patient and seeing cardiac motion?
No, it wouldn't be. And just to clarify for the reader, so donation after cardiac death, or what's referred to as DCD, these are the patients that have a severe injury but have not progressed to brain death, but essentially have an unrecoverable event, but still have normal cardiac function, normal perfusion of their organs. Through the conversation with the intensivist and the other providers at typically a level 1 trauma center or other hospital, the family has made the determination that they want to withdraw support. And obviously, as there is a federal rule in place that if anybody is pending death, that hospital is encumbered to reach out to the organ procurement agency so that the appropriate experts can then approach the family about organ donation. That's the process that occurs everywhere in the U.S. Some places are, how should I say, better at following through on all these steps, some not so good. But then I'll leave it at that. But then if that family decides that, yes, we want to donate our loved one's organs, then again, depending on the local established criteria for withdrawal of support, the patient is taken off life support. They, again, have to have cessation of function, and the accepted amount of time is 5 minutes before the process of organ retrieval recovery can be initiated. But obviously consent and everything else has already taken place prior to withdrawal support. So this is a controlled process. And
the metric that's used in most protocols for that is based upon circulatory criteria, which is usually a peripheral pulse. Is that true?
blood pressure, and obviously peripheral pulse is because most of these patients have an art line in, so most centers are using blood pressure as a confirmatory, but a peripheral pulse would work as well, along with looking at O2 saturation and CO2 levels, and a combination of this, because there's that quasi point you get into where the person has electrical rhythm, but their pulse obviously is undetected, so that's why most centers are still most of the patients usually do have an A line in, and they use that to help determine when they've crossed that threshold.
Now we're also seeing let's call it an extension of indications for donors, especially elder donors. Is this good, bad, or is this just a response to the need for more donors?
So certainly a response to the need, the supply-demand component. I'll do my one little blurb for transplantation. There are currently 110,000 people listed for a solid organ transplant in the U.S., and we average roughly 7,500 to 8,000 donors a year. So, and there is a growing disparity between the need of, and these are just people listed, and the number of donors that we have. And so because of that disparity, we continue, there are two parts. Because of that disparity, we continue to reassess how do we improve and expand our donor pool. I always tell the story that was told to me that when organ transplantation first started out in the 1970s, really the transplant surgeons were roughly in their 40s, and the oldest donor they would accept was 40. And a decade later, they said, no, I think we can go up to 50. And then the decade after that, 60. We are now, seriously looking at donors in their 70s and even into their 80s. Obviously, the donor that gets to their 80s may have other health issues or may not, because by definition, to get to your 80s, you have to be pretty healthy. Those donors, again, their organs can be safely and successfully used, but again, you have to look at each organ and each donor through an individual lens to match up for your patient.
And I know we have had questions about medical tourism in the past. In CSAP 17, the question about medical tourism did not quite make it to the final cut. So is this still a problem in the world of transplantation?
So the issue of medical tourism, which always leads to a lively discussion at the CSAP study sections, whether the question makes it all the way forward, is still an issue. I think we would be somewhat blinding our readers if we thought that it went away. Medical transplant tourism occurs in several different ways. One is where there are transplant centers set up in different parts of the world. Donors, typically from lower socioeconomic status backgrounds, are basically recruited to donate an organ or a part of an organ at these centers. The middle people, the brokers, walk away with most of the money. The donors walk away with a very morbid operation, little follow-up, and little money, and then there's a recipient. That still occurs. Obviously, it is under intense scrutiny, and I think the last major Interpol involvement was maybe 3 or 4 years ago, and this was either the program in Turkey or in South Africa. But I imagine this will never fully go away because of the supply-demand discrepancy.
Just out of curiosity, when this happens and somebody comes back to the United States, their follow-up is then placed on your shoulders?
So that's an ethical discussion that occurs at each transplant center. And, taking care of the patients is what we do. Certainly in my career I've had, again, no more than a dozen patients come back that have been transplanted overseas and given a chart that's in a language other than English and a large incision, and we're sort of picking up the pieces a little bit like Humpty Dumpty. Sometimes everything works out okay. More often than not, those patients don't have the same outcome that our patients that are transplanted in the U.S. have.
Well, let's talk about living-related donors. It was during the production of CSAP 17 that we had some horrific, let's say, I won't call them mistakes, but screw-ups about living-related donors. And is this practice increasing? Are the dangers such that we're going to see less living-related donor activity? Can you give us some perspective?
Yeah, this is the area that continues to, as I say, be richly discussed in the transplant community and healthcare in general. So when we look at living-related donors or living unrelated donors even, and altruistic donors, really we're talking about two organs, kidney and liver. Kidney living donation, that's how kidney transplant started in the 50s. It has increased over 5 decades. We have periods where it suddenly falls off, which typically are associated with a negative public relations story, and then it picks back up. Partly the reason there was such growth in living kidney donation is with the advent of minimally invasive surgery. I don't think it would ever go away. I think there is a risk, obviously, that we have to be extremely mindful of in the process and educating the donor as well as the recipient, but for the donor of what that risk is because they're undergoing a general anesthetic and a major procedure. For a center to be embarking on this, UNOS, which is United Network of Organ Sharing, which is the independent contractor for the Organ Procurement Transplant Network, which is, again, functions under HRSA and HHS, has set up certain parameters for a program that are required to successfully and safely have a living donor program for any organ system, and this includes having an independent donor advocate for the donors so that there is proper stewardship and guidance and that independence and autonomous decision-making for the donor. And again, there have been negative stories, as you point out, in living kidney donation. So we can never get away from that there is a risk there. Living liver donation is something that started in the late 80s. It grew initially in the late 90s and then backed off. And there are certain programs with tremendous expertise around the world in living liver donation. There has been an increasing demand for living liver donation in the U.S., and this ties to the fact that the prevalence of non-alcoholic fatty liver disease is negatively impacting our deceased donor population. So it's negatively impacting the growth of our transplant waiting list, but it's negatively impacting our deceased donor supply because we're seeing just so much metabolic syndrome and fatty liver disease in the population that the community wrestles with expanding living liver donation as a way to help sort of meet that need for our patient population. And I think, we will continue to have an extended conversation and debate. The number of living liver donation transplants is small relative to total transplantation. It has grown some, but it has not grown significantly compared to, say, living kidney donation.
I need help understanding a term because in our children's hospital, they are now talking about split liver donation. Can you help me? I'm yet to understand exactly what that is.
I doubt that. John, I believe you do understand that, but I appreciate the question. It's an important one. So obviously the liver anatomically, as we all came through med school and residency, we were taught about the arterial and portal supply and biliary supply in the liver when we started referring to the liver in segments based on the Quinaud segmentation. There are 8 segments of the liver. Split liver really is the offshoot, the clinical offshoot of knowing that in our children's hospital, the pediatric liver patient needs a appropriately sized liver. And when we look at deceased donor populations, there is an underrepresentation, thankfully, in pediatric donors. But unfortunately, that comes at a penalty for our potential pediatric recipients. What we know is that the segment 2 and 3, what used to be referred to as the left lateral segment, volumetrically, it meets the need for our pediatric patients, and that's a way to do a living donor transplant using those two segments, or segment 2, 3, and 4, depending on the size of the recipient, but more often segment 2 and 3, being able to successfully do that liver transplant. That's the living donor version. Now, taking it a step further, because there is a discrepancy or disparity between the number of pediatric patients needing a liver and the number of appropriate sized liver donors, meaning pediatrics, we can look at split liver transplant, which is if we have that ideal donor where we could split the liver, meaning taking segment 2 and 3, giving that to the pediatric recipient, we would still have segments 4 through 8 for an appropriate sized adult patient. And that is something, again, we talk about a lot. We've tried to expand that. I think we struggle with expanding it a lot, partly because you really do need the pristine donor. And the pristine donor, everybody's coming for an organ. It's now we're talking about multivisceral, we're talking about intestine, we need the liver, can we split the liver? And again, there's a limit to how much we can put these organs through and still have them successfully used in our recipients. So it's a sort of a push-pull in of the ongoing debate.
Well, let's give our audience, who probably many of them don't hear about organ transplantation on a daily basis. Can you give us some outcomes of the various transplants that we're doing? So let's go way back in history and let's start with our renal. Are we getting better?
We are. So the rough numbers on 1-year outcomes for kidney transplant, living donor kidney transplant, 1-year outcomes are 99% or greater. And 1-year outcomes for deceased donor transplant are at 95% or greater. So we really have improved significantly, almost to our own challenge, because transplant is one of those fields which is transparent public reporting. So our providers, our other colleagues, patients can go online and they can look at a center's outcomes, and 1-year graft and patient survival are publicly reported outcomes.
And what about liver transplant?
Liver has also improved significantly over the course of my career, where now I would say the national outcome for 1-year graft and patient survival is between 92 to 94% plus.
And what about longer duration?
Longer duration, so it's interesting, longer duration for liver at 3-year outcomes, the national outcomes they go from that low 90s, they drop down into the mid to high 70s. And if they get beyond that 3-year outcome, that survival outcome actually plateaus. So for those liver patients, they actually can do very well. And again, this is benefit from the antiviral therapies that are out there and other behaviors which will help protect that new liver. For kidneys, what we see is that 1-year outcome drops from that 1-year high 90s, mid to high 90s, down into the 80s, low 80s at 3 years. And it still continues to fall off significantly, but partly that reflects everything else going on in that patient and the contributors to what caused their chronic kidney disease, which is usually diabetes and hypertension, 2 diseases that those patients still have after their transplant.
Well, yesterday I sat down with one of your CSAP colleagues, and we had a discussion about one of the ethical questions in CSAP 17 that relates to a very sick child, whether or not the small bowel could be salvaged or not. And the question was revolved around figuring out if this was a valid use of resources for a small bowel transplant. So can you give us some update on where we stand on small bowel transplant, which I know is a challenge to transplant surgeons all over the place?
Right. So, this is one of our niche areas, the small bowel transplant. And I refer to it as niche because it's small volume, low numbers. You're looking at 100 plus minus transplants per year. Again, just like our other solid organs, the 1-year outcomes have continued to improve. It is done in a small number of centers because, like anything else, a lot of complexity, requires a lot of expertise beyond the surgeon to be able to successfully and safely take care of these patients, but clearly no longer what I would refer to as research or not yet there. It is definitely in the clinical prime time, but it has to be, I don't want us to think that everybody should have a small bowel transplant program.
One of the things that has to be impacting your results is immunosuppression, which is always a topic, again, for test questions. But are there some common workhorse drugs that are really making a difference today?
Yeah, so the calcineurin inhibitors, which are tacrolimus and cyclosporin, really, they're the workhorse of transplantation. They're not the only drugs, but they certainly, their advent really changed our outcomes. And in both ways, learning how, again, having more potent immunosuppressants, but also learning how not to over-immunosuppress patients. So it had been a learning curve. In combination therapy of immunosuppression, much like other areas of medicine, have really benefited because then you're minimizing the toxicities and the side effects of the different drugs. And it's important for our general surgeons or our non-transplant colleagues to know that many patients will be on immunosuppressants today. And again, I get this call usually half a dozen times a year, usually from a general surgeon or an orthopedist that's going to be operating on a patient wanting to know what to do. And I tell them, just tell the patients to continue to take their meds the way they've been taking them. Obviously, if it's a very fresh transplant, those patients really should be managed at their transplant center unless it's an emergency. And if it is an emergency, have that patient resume their transplant meds the way they were dosing them before as early as possible. But there is an obligation of the provider to make sure that appropriately timed drug levels are being sent off. And those can be obtained anywhere in the world now, so that we make sure that the patients are not becoming either super therapeutic or underdosed on their meds.
Are there either drug complications or drug interactions that are common with your common immunosuppressive drugs that we as general surgeons need to be aware of? We may not need to know how to treat it, but we need to be aware of it so that we're careful.
Yeah, so the answer is yes and yes. Again, so there are multiple drug interactions or potential for drug interactions, and that's why obtaining the drug levels, there are the classic drugs, again, most of our agents are processed through the cytochrome P450 system in the liver, and there are other drugs that either slow down that metabolism or enhance that metabolism. The more common drugs that we talk about are things like the erythromycin agents. Calcium channel blockers can play a role. There really is a long laundry list of things that are inducers of P450 pathway. And it's funny, this is where if you're at a center like mine, you have a pharmacologist, a PharmD on your team that's looking at the drugs and, again, trying to be proactive with what we do when we add other agents. The azoles are another drug that come into play. I think it's important to know what your resources are as a general surgeon if you're taking care of these patients, and reaching out to the transplant center that is home for that patient. Transplant patients really do have a care team for life, and they have a coordinator, a nurse coordinator, and a transplant center. So reaching out when you're taking care of that patient gets you in touch with that transplant coordinator. And again, with that comes, you'll get the transplant PharmD and the transplant center's expertise, so that this way we can co-manage that patient. And I think that's the best way to approach it for the patient's perspective.
I will tell our audience that in the ICU, when we're dealing with our transplant patients, not only is the transplant team totally important to be on board, but that PharmD keeps us out of trouble almost on a daily basis, I swear.
I agree with that.
They remind us constantly that, let's think about this a little longer. So, David, I see our time is almost up. I really have enjoyed talking to you as usual this morning, and you've been a great addition to CSAP 17, and I just give you the opportunity for any closing comments about the CSAP process or CSAP Audio Companion.
first off, I have to say thank you for inviting me to participate. The CSAP process is truly, to me, as I've lived it on both sides, is a rigorous process that folks who participate, whether they're as surgeons using the educational tool or those who have helped sit through in developing the questions, there's a lot of effort that goes into the process to make sure that you're capturing things that are germane to the community, to the patients, and to the surgical community at large. I think the audio companion piece has been a welcome addition. What scares me is when I run into people later on and they go, oh, I was using CSAP and I heard your voice when I was driving in my car. And my first thing is, oh, gosh, I hope you didn't crash. That distraction would occur. But, I get so much positive feedback from individuals that the dialogue that you've brought, in making this product come alive in the audio companion, I can't say enough great things about it.
Well, that's good. I appreciate that, and it wouldn't be a great product without people like you who are willing to give of themselves, their time, and their expertise to make it what it is. So I thank you sincerely.
A pleasure, John, and likewise to you, and hopefully the weather doesn't come up too strong on you as the winter fast approaches.
Okay, thank you.
Thank you.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.